Good morning, everyone. Today, I'm going to talk about diabetic nephropathy, the current treatment of diabetic nephropathy, and it is called a pillar approach of diabetic nephropathy to decline or decrease the progression of diabetic nephropathy. So first, we'll talk about the prevalence of diabetes. There is 588 million people currently living with diabetes around the world, and in the MENA region, which is Middle East and North African region, and the prevalence is of diabetes is around 12.2%. In Bahrain, especially, it is around 11.5%. It has gone down from 19% in 2011, and it went down to now is 12%. But problem is like 44% of the people, they don't know that they have diabetes. If we look around the globe, the prevalence of diabetes, it is increasing, especially in African region and MENA region, which is increasing by 92%. Also, Southeast Asia, it is going up by 73%. So by 2050, it is expected that there will be 850 million people who will be living with diabetes all around the world. So patient with early diabetes has increased risk of complication due to metabolic disturbance and interconnected risk factor. For example, if the patient having diabetes and on top of that, they have hypertension, dyslipidemia, smoking. So they are increased risk of diabetic microvascular and macrovascular complication, like microvascular complication as diabetic nephropathy, retinopathy, and neuropathy, and the macrovascular complication like MI, stroke, peripheral vascular disease. So if you see if even among all the complication, diabetes, the kidney disease is an early and highly prevalent complication of type 2 diabetes. There are almost 50% of patient with type 2 shows evidence of chronic kidney disease. And type 2 diabetes, even at the time of diagnosis, you will find that patient has underlying chronic kidney disease, and it progress over the years comes. So regarding the causes of chronic kidney disease, diabetes is the leading cause of chronic kidney disease. Diabetes causes around 40% of patients with chronic kidney disease, followed by hypertension, which is 30%, glomerulonephritis, and cystic kidney disease. So if there is a diabetes and chronic kidney disease, they are coexisted, this cause more high mortality as compared to patient who has only diabetes. The mortality rate is around 4.1%. If patient has type 2 diabetes with albuminuria, this increase the mortality to 17%. If patient has type 2 diabetes with low GFR, the stage 3 CKD, the mortality go high up to 24%. And if patient having diabetes with albuminuria and low GFR, the mortality go up to 47% over the 10 years of period. So how long it takes for diabetic patient to develop chronic kidney disease or diabetic kidney disease? In type 1 diabetes, it takes around 10 years, most like somewhere between 55 to 15 years. But in type 2, we cannot predict. Maybe it is present at the time of diagnosis of type 2 diabetes. So how the kidney disease is defined? It is defined as reduced kidney function with the presence of kidney damage of more than at least of 3 months or regardless of kidney function. We detect in by checking albuminuria, abnormal urinary segments, and sometimes we also need kidney biopsy where we are not sure that what is the cause of kidney disease. And the clinical diagnosis, we need two things, basically the urine albumin creatinine ratio and declining GFR in the presence in the absence of any other cause of kidney disease. So how frequently we should screen this patient who has without diabetes, in people without established diabetic kidney disease, they should be screened for urine albumin creatinine ratio at least once in a year, or also eGFR at least once in a year. But patient who has already established diabetic kidney disease, they should have urine albumin creatinine ratio at least 3 to 4 times per year. Same goes with the EGFR as well. But mostly this urine albumin creatinine ratio is always lacking. We do see in developed countries like US, where they showed that more than 1 million people, which shows like electronic health record of 39 healthcare organization, which they showed that only 80% of patient showed who has GFR less than 60 ml per minute, only 80% of patient was checked for albuminuria. So why albuminuria is very important? Because this is the marker of early damage to the glomeruli, or vascular damage or endothelial damage. So whenever there is endothelial damage, you will see there is albumin in the urine, and that is also marker of cardiovascular disease. So albumin urea should be checked ahead of GFR. So this is how the chronic kidney is classified. There are five stage of chronic kidney disease depending upon EGFR, and now they have further classified on the albuminuria as well as. So this is called heat map, which actually guide not only the primary care physician, also the internal medicine doctors and nephrologists, when to screen and when to refer to the patient and how to treat those patients at what stage. So regarding pathophysiology of diabetic kidney disease, this is the natural history of diabetes. When we see hyperglycemia in the patient, we usually see within 1 to 2 years of hyperglycemia, there will be hyperfiltration and high GFR. At the same time, we see there is a cellular level injury, which leads to microalbuminuria and hypertension within 5 to 10 years if the diabetes is well controlled. I'm talking only those patients who has diabetes well controlled. If it is not controlled, then it can lead to mesangial expansion, glomerulosclerosis, macroalbuminuria, kidney complications within 5 years or so. But if it is well controlled, it usually takes somewhere between 10 to 20 years. So whenever there is hyperglycemia or associated dyslipidemia, this increases the advanced glycolate end products, which are actually bad. This is the triggering factor which increase the macrophages recruitment, causes pro-inflammatory and pro-fibrosis factors, which is going to be deposited in glomeruli and cause the kidney damage. Basically, the pathophysiology depends upon 3 factors: metabolic dysfunction, inflammation, and hemodynamic problems. So these all 3 factors can lead to kidney damage. So that's why we have to plan our treatment by dealing all these 3 factors. So again, this is the different pathways and network involved in the initiation and progression of diabetic kidney disease. Hemodynamical problem, especially when there is increased ROS system activation or increased endothelial activation. When metabolic system is involved, there is increased AGE, which is advanced glycogen end products, and also the TGF beta factor, which is pro-fibrotic factor, anti-inflammatory factors. All these pathways can lead to the intracellular signal pathways, which further initiation the damage of causes the glomerular hypertrophy, mesangial expansion, and tubular interstitial fibrosis, glomerulosclerosis, and kidney fibrosis. So this is to compare how the normal glomeruli look like and how. So this is the normal glomeruli. When there is diabetic kidney disease, you will see there will be a thickening of the GBM. There will be a foot process. This is the normal foot processes of the GBM. You will see there is fusion of the foot processes, and there will be effacement of the podocytes, and there is mesangial proliferation as well. Normally, there are 3 to 4 mesangial cells. Here in diabetic, you will see more mesangial proliferation, which shows the damage to the glomeruli. This is under pathology slides. We can see this is normal glomeruli. There will be a diffuse in diabetic nephropathy. There will be diffuse mesangial expansion, which leads to nodularity, and which further develop a Kimmel-Still Wilson's nodule, which is pathognomonic of our diabetic nephropathy, and further it leads to the glomerular sclerosis of the glomerular and diabetic nephropathy. This is under electron microscope where we see same changes but more prominent, like mesangial proliferation, thickening of GBM, and effacement of epithelial foot processes. So we're talking about the glomerular damage. What about the direct tubular damage? So whenever there is glomerular damage, there is podocyte period injury, which cause glomerular leakage and proteinuria. But if the tubules are intact, tubules are bound to retrieve whatever there is albuminuria. But in diabetes patient, there is a damage to the glomeruli and also at the tubular level, which causes what potentiate the kidney injury, causes microalbuminuria, and further there is a cascade of event causes hyperfiltration as well. So glomerular hyperfiltration, usually we ignore this patient, but this is the first sign where we can see in diabetic patient that there is kidney injury is going to start. So what is glomerular hyperfiltration? When the GFR goes up to 135 ml per minute, which is absolutely supraphysiological in terms of diabetic patients. It is seen in type 1 diabetes around 10 to 67%. In type 2, it is 6 to 73%. It's variable, but it is independent predictor of adverse cardiovascular outcome as well as all-cause mortality. So what is the management of diabetic kidney disease? It is always based on like multifactorial management. The base is with lifestyle modification and diabetes education, and then goes with tight glycemic control, blood pressure management, lipid management, and then the agents which can help us to protect our kidney and the cardiovascular system. So what the guidelines suggest, like American Diabetes Association, regarding the control of diabetes, it suggests that the glucose control should be with HbA1c of less than 7%. It can be controlled by metformin with SGLT2, GLP, whatever lot of options we have available. Blood pressure control should be below 130 by 80 in high risk cardiovascular patient, and those who has low risk, it should be below 140 by 90. The LDL should be below 100 in moderate risk of cardiovascular disease, and it should be below 70 in high risk patients. Smoking cessation, weight loss more than 5%. Some studies suggest more than 7%. More than 150 minutes per week of exercise. This is all lifestyle modification, of course, with the monitoring of kidney function by looking at the urine albumin creatinine ratio and eGFR. These are the basic management of diabetic nephropathy. So I just want to show one thing about the how strong or how quickly we can correct that diabetes, and what should be the target of HbA1c. So this is just a CORD trial, which actually was terminated within 3.5 years of initiation of the trial. This was actually looking intense versus standard glycemic control. Intense means HbA1c was less than 6, and the standard means HbA1c between 7 to 7.9. Why it was terminated? Because they have seen that there was more increase in mortality when the HbA1c was 6.1. Why there was more mortality? Because one is increased risk of hypoglycemia, and then increased risk of fall in those patients, and there was also some neurological problems in those patients who has less like tight control of HbA1c. So that's why they kept the target of HbA1c around below 7. So we talk about the pillar-based therapy for diabetic nephropathy. The first pillar is renin-angiotensin system blockers. This goes back to 1993, when there was first trial on captopril for type 1 diabetes, where this shows that there was 11% decrease of decline in GFR as compared to 17%. Then followed by there was these two famous trial, renal trial, which compared actually placebo versus losartan, where they found that there was 16% risk reduction of doubling of creatinine, end-stage renal disease, and death. And on the other side, there was another trial which was actually comparing irbesartan, amlodipine, and placebo, and where they show that irbesartan group has 20% relative risk reduction of doubling of creatinine, doubling of end-stage renal disease, and death in these patients. So this was actually the second trial after the captopril trial, which encourages us that there is something to offer to our diabetic patients. And followed, this was published in 2001. After 2001, there was many molecule came, but like we have this protein kinase block inhibitors. There was endothelin antagonist, and there was famous L-carine, which was in 2011. Which was direct renin inhibitors. Then there was some evidence that if you combine ACE inhibitor in ARB, it gives you more protection. But this was disastrous because patient has high mortality because of hyperkalemia by combining those factors. So there was nothing to offer in between those years from 2001 till we see the second pillar, which shows some evidence at the initial in 2014 with the introduction of SGLT2 inhibitors. So how does this SGLT2 inhibitors work? Actually, it enhances the excretion of glucose, sodium, and water into the urine. So this is why we call that the SGLT2 give us salty and sweet urine, because it excrete not only glucose but also sodium it carry. So if you see here, this is S1 segment of the proximal tubule, where there is SG sodium glucose co-transporter on the S1 segment. There is so this actually causes the sodium and glucose reabsorption. So SGLT2 inhibitor actually block this one. So how does it help? So in normal days, if we have a serum glucose of 100 milligram per day in the fasting, so we have, and our GFR, normal GFR is 180 liter per day. So the filtered glucose will be 180 gram per day. So 90% of that filtered glucose is blocked here. So remaining 10% goes down to segment 3 of proximal tubule, where SGLT1 receptor is there. So 90% is blocked. So that glucose and sodium is going down and is being excreted through the urine. That is the ideal situation. Although these medication does not work like that, they only have efficacy of a 30 to 50% blockage of SGLT2 inhibitor. This is a very good slide, which actually shows that how the pathophysiological mechanism implemented to protect the kidney and the heart. So, as I said, it causes glucosuria, which can cause negative calorie balance. And how much is the negative calorie balance? As if we say that if the patient has a glucose filtration is around 180 gram, and SGLT2 is blocking there about 50% of that. So that means if patient is losing 100 gram of glucose, if we divide 1 gram of glucose multiply by 4 of calories, so patient is actually losing 400 gram of kilocalorie of calories per day. So that's why it causes negative balance. This is how they lose weight, by depleting the calories. On the other side, HbA1c decreases if we decrease its control, it decreases the inflammation. It also helps us to pass more extra uric acid into in the urine, and by natriuresis, it causes decreased blood pressure and decreased plasma volume and increased tubular glomerular feedback system. All these factors actually at the end help us by decreasing the inflammation and fibrosis, decreasing the atherosclerosis, decreasing the hyperfiltration, and leading to protect our kidney and the heart. So SGLT2 inhibitor, the first trial, which was actually a real trial with empagliflozin. which actually suggested that it helped us by reducing the primary outcome of kidney outcome by 39%, and also for the cardiovascular outcome by 38%. Then comes to Crescent's trial, which involved canagliflozin, which also predict the same results by reducing 30% of primary outcome of kidney disease, like doubling of serum creatinine and stage renal disease, death due to cardiovascular kidney disease reduced in 30% in canagliflozin as compared to placebo. Then comes to this landmark DAPA CKD trial, which actually involved the dapagliflozin. This was an international multi-center trial which involved more than 4,000 patients. This had almost 74% of patients having diabetes and 26% was without diabetes. And this trial actually terminated within 2.5 years because the efficacy of this molecule was huge, so they have to terminate to give this benefit to all placebo group as well. So what it showed, it actually showed there was 39% reduction in the relative risk reduction in patient who were using dapagliflozin in primary outcome, which was again the same 50% decrease in decline in GFR and developing of ESRD, cardiovascular renal death. So there was like 39% relative risk reduction in dapagliflozin. Not only that, there was 31% reduction in all-cause mortality and 29% reduction in cardiovascular deaths. So in the clinical, like day-to-day practice, how does this trial help? This shows that if you start this molecule, if the patient's GFR has 30 ml, and if you start this dapagliflozin, the declining in GFR will be 1.48%. And if you don't start, then the declining in GFR will be 3.2%. So that means if the GFR goes, like take longer time to decline with dapagliflozin, and we can delay the dialysis in this patient by 6 years. And even if you start this molecule, if the patient GFR is at 60 ml per minute, then we can delay the dialysis 11 years. This is another great trial, empagliflozin, EMPA-Kidney trial, which also actually replicate the same result as DAPA-CKD, but it was having diverse population involved. It involved those 50% of the patient who has diabetes and 50% who didn't have diabetes in this trial. And they involve the mild degree of CKD to the extreme severe reduction in GFR without background of usage of irosolic. So it also showed there was 28% relative risk reduction in kidney disease progression, and then 14% relative risk reduction in all-cause hospitalization.
Well, that's so. What other patients did they include?
They included mostly diabetic patient, but like this was to diversify. They also included a patient with IgA nephropathy, FSGS patient, but the number was very less. But IgA nephropathy, there was quite good number of the patients. So how this is again, these trials are terminated within 2.5 years because the efficacy of these molecules. So this trial also showing like if you start this empagliflozin at 20 ml of GFR, and so it can delay the decline of GFR by 1.9 years. And if you start this molecule when at the initial stage, when the patient GFR is 85 ml or 90 ml or so, so it can delay the declining of GFR to up to 10 ml, where the patient need dialysis by 26 years. So huge difference. It's not only delaying the dialysis, it is also the burden of economic burden. Patients, patient go a lot of agony because of the comorbidities and all those things, healthcare expenditure, so many things we can help to the patient if you start these molecules. So looking at all these four molecules of SGLT2 inhibitors, KDIGO guideline suggested that SGLT2 should be added if a patient who has underlying diabetic or non-diabetic kidney disease, and if the patient is already on glucose lowering agents, it can be added. And the choice of SGLT2 depends upon the current evidence which molecule is good, but as we said that DAPA and EMPA both are equally good, so it can be used. There you will definitely see there is an initial dip in the GFR, but that is always reversible. So it's better to check kidney function after 1 month of starting of these molecules. And once you start these SGLT2s, even the GFR dip down below 20, you should not stop, because there are also cardiovascular benefit, not only kidney benefit. So we need to continue with that. We should hold these SGLT2 if patient having prolonged fasting, if they are undergoing surgery or they have underlying medical disease. If patient is already on diuretic like thiazide diuretic and loop diuretic and they have a risk of hypovolemia, we should stop these for a while. And there's no evidence that if these can be used in kidney transplant, so we should not use these things. And the third pillar of diabetic nephropathy is mineralocorticoid receptor antagonist. So these are actually, we will go with the slides. So in diabetic, in normal conditions, mineralocorticoid receptor, there is activation, it will regulate fluid and electrolyte homeostasis. But in diabetic patients, so there is overactivation of these receptors, which can cause all the, which can be driven by the metabolic, hemodynamic, and inflammatory and fibrotic factors, which can damage to the kidney, as you dynamic effect of ACE inhibitor and ARB. We already discussed about the SGLT2 inhibitor to deal with metabolic issues in diabetic patients, but we didn't discuss about inflammation and fibrosis. This is being dealt by the Finerenone, which is known as okay. So Finerenone, which is actually the mineralocorticoid specific. This is non-steroidal mineralocorticoid receptor, which actually block decrease the inflammation and fibrosis inside the kidney. So there are two great trials, phase 3 trials, which shows the benefit of Finerenone in diabetic kidney disease. Fidelio CKD and Figaro CKD trials. Basically, this trial was the primary outcome for one for the renal, one for the heart, and the secondary outcome was all-cause mortality, all-cause heart hospitalization. So actually, these trials, Fidelio CKD trial include the population with severe kidney disease like CKD 3 and 4. It shows that there was 18% decrease in CKD progression, 14% decrease in cardiovascular mortality. On the other side, Figaro CKD trial was included mild degree of CKD, and it shows there was 13% reduction in cardiovascular mortality and 13% reduction in CKD progression as well. So adding by these, after the evidence of Fidelio and Figaro CKD trials, what you call this latest guideline have included this in the treatment as well. So this Finerenone not only helped further to achieve the primary outcome, it also suggested that there was a reduction in proteinuria by 31%, and it was maintained throughout the year, throughout the study course. And also there was a initial dip in the GFR, but then in the long run, the difference of GFR was 1.3 ml between Finerenone and versus placebo group. So only concern with these MRA antagonists is always hyperkalemia. So in this trial, they showed there was not marked difference in hyperkalemia in this patient. So it is actually safe to use if the patient's potassium is below 5. So looking at this trial, the KDCO 2022 also suggested to add mineralocorticoid receptor antagonists like Finerenone with proven chronic kidney disease and cardiovascular benefit if the patient GFR is more than 25 ml with normal normal potassium and proteinuria. So these are all these recent guidelines which are including Finerenone and as a second or third third pillar of diabetic nephropathy. The pillar number 4, which is GLP-1 in diabetes, kidney disease, we have seen that ROS blockage, mineralocorticoid receptor antagonist, and SGLT2 inhibitor, they are all beneficial, but there is still some residual risk of developing chronic kidney disease. So that's why there is another pillar, and in future we might need more further treatments as well. How does they work? By direct mechanism, GLP-1 increases natriuresis and diuresis. It decreases oxidative stress in the glomeruli and also decrease atherosclerosis. Indirect effect by losing weight, by controlling the blood pressure and sugar, it helps to protect the kidney. So there is only one trial which is actually randomized controlled trial. It's an international trial with known as FLOW trial, which was recently published in May 2024, which actually show there was 24% reduction in major kidney disease event in patient who was taking semaglutide as compared to placebo group. And there was also benefit with cardiovascular mortality as well. So we all discuss all these 4 pillars of guideline derived medical therapy for type 2 diabetes. Number 1 is ROS blockage, SGLT2, non-steroidal mineralocorticoid receptor antagonists, and GLP-1. So this is how they all work. They work on these pathways of metabolic dysregulation, inflammation, and hemodynamic, and they help us. Though in the real, this is just to understand how GFR decline in diabetic kidney disease. In normal people, there is decline in GFR of around 1 ml per minute per year after the age of 40. But if somebody who has diabetes and it's not controlled, their decline is fast. It is around 5 to 7 ml per minute. If you introduce all these pillar of treatment one by one, like starting with the ROS blockage, then SGLT2 and MRA, and then GLP-1, we can actually slow down the progression of kidney disease by 1.5 to 2.6 ml per minute. It's not normal, but it's close to normal decline in GFR by introducing this pillar of therapy.
What's normal?
Normal is 0.7 to 0.9 ml after the age of 40. So 10 ml per decade after the age of 40. So it can delay the dialysis. Yes, it can delay. These therapies can help us, not only dialysis, renal replacement therapies like need of transplant as well in diabetic patients. It can delay up to 3 to 5 years. Like in high risk patient, they might need within 3 to 5 years of diagnosis of diabetic nephropathy. But with all this combination, theoretically, we can delay at least 5 to 10 years, provided if what is the stage of chronic kidney disease, what is the degree of albuminuria, and how good is their glycemic and blood pressure control. So in conclusion, diabetic kidney disease affect almost 700 million people worldwide and has 3-fold higher risk of all-cause mortality than in people without diabetes. Looking at this complex pathophysiology of diabetic kidney disease, we should go with the pillar approach as they do in cardiology for the heart failure management. So we should, in a sense, after the institution of this ROS blockage, we have multiple other options like SGLT2, MRA, and GLP-1, which can help us to slow the decline of GFR in diabetic kidney disease. Thank you.